Good morning, everyone. And this is going to be a great session. Cracking calcium, best practices to integrate intravascular lithotripsy into your calcium management algorithm. I don't have any conflicts of interest to declare. We well realize that calcified lesions are a nemesis for interventional cardiologists, truly. When I see a heavily calcified vessel, I say, oh my God, why me? And this is increasing in our practice. 25 to 30% of the patients of the lesions that we deal with have some element of calcium, and heavily calcified lesions clearly constitute 10% of the patients that we're dealing, heavily calcified. That's because we see more elderly patients, there are diabetics, there's patients who got lesions for a long period of time, have had previous bypass surgeries, have diffuse disease, are diabetics. And calcified lesions and vessels are more prone for failure of stent delivery, very difficult to get stents down tortuous calcified anatomy, more prone to dissections, perforations, undilatable lesions, stent under expansion, which portend worse outcomes in terms of stent thrombosis as well as restenosis. Of course, a number of tools have come in over the last 10 years, I would say, more so over the last 10 years, which now allow us to deal with calcium much more effectively to get better outcomes for our patients. We also have imaging modalities to help us decide which tools to use and how to get the best results. Of course, beyond the scoring and the cutting balloons, which I believe are for mild to moderate calcification, has been atherectomy devices which have been with us for a long period of time. And they really play an important role. But more recently, we also have intravascular lithotripsy. Today, this is what we're going to talk about, intravascular lithotripsy, the device which is easier to use, is effective, but we still need to understand where, how, when, and understand the best practices of using the device to give our patients the best possible results. And we well realize the whole philosophy around it, so we're going to discuss around the mechanism of action. You all know that. It is acoustic waves which actually crack the calcium. I think today's learning objectives are more important, and that is to know the evidence from trials and outcome data for intravascular lithotripsy in heavily or severely calcified lesions. We need to understand how to use this device, a novel device, in real-world patients with severely calcified coronary lesions, and also to understand the appropriate role of IVL in our treatment algorithms for severely calcified lesions. So with me is my co-moderator, Dr. Mirvat from Saudi Arabia. We have tremendous panelists with Dr. Sarita Rao from India, and of course, we have the other speakers who also are a part of our panel, which is Dr. Sidney Lowe from Australia and Dr. Fahim Jaffrey from Singapore. With that, I think we move over. Dr. Mirvat, over to you.
Well, good morning, everybody, and thank you for joining us. We do want this to be an interactive session, so between the lectures, we do have dedicated time for Q&As and questions and discussions with the audience. There are microphones on the floor, so please do reach out and voice your questions when the time slot comes. We also have an online application, so for those of you who are joining us online, and even those of you in the audience who want to go to slide.com and use the QR code to sign on, if you don't want to speak up at a microphone, you can post your questions. And our chat master, Dr. Davinder Chada, is already online, and he'll help channel the questions over to us, and we'll get to them in due time. So without any delay, we move on to our first speaker, Cracking the Calcium with Intravascular Lithotripsy, Overview and Real-World Evidence. And with us is Dr. Fahim Jaffrey. So over to you.
Thank you, Dr. Alasnag. Let me go to the slide. So I'm grateful for the opportunity to give this talk today. So in the next 10 minutes or so, my job is to talk about the use of IVL and talk about the guiding principles that are behind using the device in a more pragmatic and practical manner. So I don't have any conflicts of interest. You've already kind of heard briefly the overview. The basic principle of shockwave lithoplasty is that essentially you produce an electrical spark in a balloon, and what that does is it vaporizes the fluid and creates these acoustic shock waves that pulverize the calcium and induce fractures, both microscopic and macroscopic, at about 50 atmospheres. And you can see on this panel on the right side, you can see this literal grenade explosion in the balloon that produces these acoustic shock waves. And you've seen this video already. Ashok was just showing it to you. In essence, the balloon has these emitters that produce these shock waves that fracture the calcium. And the fractures, and just to look at the anatomy of the balloon briefly, the balloon is basically a 12 millimeter balloon in various sizes, from 2.5 up to 4. And in the center of the balloon, but more off-center, you have these emitters, which essentially emit the electrical pulses. And the location of the emitters is important to understand, that they are sort of more situated proximally rather than distally, so it's a bit off-center. So the emitters are not in the center of the balloon, and that has implications on how you position the balloon when you're doing these procedures. And as I said, the calcium fractures are both macroscopic as well as microscopic, and that's how the device works. So enough of these pretty pictures. Let's look at some more ugly pictures, and let's try to do a case together and look at the guiding principles behind IVL. And so here you have a 66-year-old woman, ESRD on dialysis, no surprise, calcified lesion, prior PCR to the LAD, presents with a non-STEMI, the LAD is patent, and the RCA is got severe calcific disease, and that's what it looks like. You can see a very, curlicue, tortuous RCA. You can see calcium distally and in the mid-vessel. And if you look at the panel on the right side, that is a very tortuous and ugly-looking right. And if I just play the pictures without any contrast, you can see the calcium. Hopefully, you can see it at your end also, that there's calcium here and there's calcium in the mid-vessel, clearly ugly. So what are the issues with this case? Well, the issues are that it's heavily calcified, it is tortuous, and that's not a good vessel for atherectomy. Certainly if you look at that panel on the right side, that is not a vessel I want to put a burr in. And so our plan, at least going in, was to go with the balloon-based strategy, non-compliant balloon or IVL, and use rotablation as a really, really last resort. And if I had to ablate, if nothing else would go, I would ablate proximally with the 1.5 and then probably use a guide catheter extension to stick it all the way down here in the mid-vessel and then distally ablate with the 1.25. And clearly that is an ugly proposition. You don't want to do that unless you really, really have to. So our equipment, going in, I thought we needed a lot of support, and we hit snags right from the get-go. So we tried a 7 French AL, 0.75, didn't fit well. Tried everything, didn't fit. Tried a 7 French AL1, didn't fit. Went with an Ikari left, didn't fit. And finally, an AR1 gave us reasonably good fit, but we're going in with a bit of a disadvantage because you don't have that much support. And what I did up front was I wired it with a workhorse wire. And this is something we do a lot in our practice. We swapped it out for a wiggle wire, which I'll show you in a little while how that's useful. It gives us more support and allows you to get the device to track down the vessel much more or much better than a regular conventional wire. And this is now the initial pre-dilation. And just briefly to show you, you can see distally, the balloon is not expanded. We went up to relatively higher pressures, and you can see sequentially as you put these pictures together, the balloon is not well expanded, but and that obviously creates problems. And so we then went with a 2.5 NC, and again relatively underexpanded. You can see not too bad over here, and then some as you come to the mid vessel, again underexpanded. So at this point, then we did IVUS, and this is playing at 3 times the speed, just for time's sake. You can see that there is some calcium distally, but then as you'll see in a second that there are multiple areas of 180 to 360 degrees of calcium, which is clearly a problem. This is not something that you can just go ahead and stent without modification. And you can see over here in the mid-vessel again, 180 arc of calcium. And as you come further up, you'll see sort of almost 360 arcs of calcium, clearly something that needs modification. And I'll just let this play out for just a brief second. Again, ring of calcium over here. Stuff that you don't want to see. So this brings us to the first principle of IVL, which is that, for preparation, you need a very good negative prep. You don't want bubbles in the IVL because bubbles don't conduct electricity. And you prep it with a 50-50 saline contrast mixture because you need saline in there. You need ions to conduct the electricity within the balloon. The second principle of IVL is selecting the right patients, and IVL works for best with concentric or heavy calcium. It also works for thick calcium. It also works for deep calcium, and may work for eccentric calcium also, but you may need more pulses. But the real value is it works well with the concentric calcium, and we saw several areas of concentric calcium over here. The third guiding principle for IVL is imaging before, and when you image before, you determine the calcium distribution. Is it concentric or eccentric? Is it superficial or deep? And it helps you determine the balloon size that you may use for IVL. And it also helps you determine where you're going to hit it with the IVL and where you're going to not hit it. And that's sort of illustrated here. We sort of stored the areas where we had the more heavy calcium or the more concentric calcium. And this has implications when you do pulse management, because you have limited number of pulses, and so you can't IVL the whole vessel. You have to be judicious with how you use the pulses. And looking at this vessel, we knew upfront this is a long lesion, and we felt that we would need 2 IVL balloons, and we decided to go with a 3-0 distal and a 4-0 proximal, and we can argue whether we could have just done it with 1 balloon. But this brings us to the next guiding principle of IVL, which is balloon sizing. And in general, you want to lean towards a larger balloon. You're only inflating it at 4 atmospheres, so it's not a huge risk. But important is that contact between the balloon and the IVL is between the balloon and the vessel wall is important, because if you use an undersized balloon, once there's some expansion, then you lose contact and then you lose efficacy. And imaging will help you decide the best possible size. And we decided based on imaging that 3-0 distal and 4-0 proximal. So this is now the IVL balloon going in. And you can see that it actually went pretty well. So contrary to what people generally say, you're often able to get it through. And this brings us to the next guiding principle of IVL, which is transit. And it indeed is a bulkier balloon. It is a more fragile balloon, so you can't shove it into very tight calcified lesions. It will rupture. Predilation is often necessary. And supportive wires like the wiggle wire or other wires are very helpful in getting the IVL balloon down. And of course, you can also use guide catheter extensions for this particular purpose. And the majority of cases, you're able to cross. And just to illustrate the principle of the wiggle wire, this is something we use a lot. The wiggle wire has these sort of corrugations or bends in the wire. And what it does is 2 things. It gives you more anchoring distally, but it also allows the balloon to find its way down more efficiently than a regular wire. And so this is the IVL now, a 3-0 IVL distally, not initially expanding, more pulses, starts expanding a bit more. And then as you can see, we Shockwave more, didn't expand so well in the mid, didn't expand again. We then went up with the 4-0, and proximally you can see it opens up very nicely, after a bunch of pulses. And then once that 4-0 balloon expanded it proximally, I also advanced it distally in the mid area, which had not fully expanded, because I wasn't too worried about putting a 4-0 balloon in a 3-0 vessel. And you can still see not fully expanded, but not too bad. And this brings us to the other point of judicious using of pulses. You think about pulses as your cash or your wallet. You have to use a pulse management strategy. And imaging helps you decide where to blast it and where to not blast it, because you have limited number of pulses. And this is then imaging post-IVL, and I'm just going to show the brief part. This is that mid-RCA area, which you can see that has still got a ring of calcium. Now, this does not mean IVL has not worked. You could still have microfractures here that you can't see, but there aren't any macrofractures. And this basically means that you have to then make sure you can expand this before you put in a stent, because the last thing you want to do is get caught with your pants down, you put a stent over here, and it doesn't expand. And so, and that then brings us to the next principle of IVL, post-IVL imaging, and that's basically to determine the efficacy and not have stent regret. And so we then took that's a typo, that's a 3-5-15 IVL, a 3-5-15 Wolverine, and we whacked it at 20 atmospheres, got good expansion. And this then brings us to the next principle about IVL, which is IVL is often something you got to use in combination with stuff rather than on its own. You have to use other adjunct devices. And basically the idea is to expand the vessel and not have stent regret. And then the rest of it is just simple angioplasty. We put in a bunch of stents, and you can see that on the left panel, a long stent tracked very nicely with all the preparation that we did. And we put in a bunch of stents, and this just to save time. This is the final result after a bunch of stents and a bunch of high-pressure post-dilation going as high as a 4-0 NC balloon. And the result looks pretty good angiographically. And then at this point, we did another run of IVUS to see what it looks like. And you can see that by and large, most of the stent is expanded. This is at 3 times the speed. Some eccentricity, which is okay. Eccentricity is not such a bad thing as long as the stent area is good. And on the lower right-hand panel, you can see that the stent areas were pretty effective and pretty good. And this again brings us to the next part, that yes, we did it without rotablation. But I would highlight the final principle of IVL, that atherectomy is still good even in combination with IVL. And you need to think in terms of combination. So Shockwave is not RRT. That's not renal replacement therapy. It is rotablation replacement therapy. You sometimes have to use a combination. Sometimes devices won't cross. Sometimes even if they cross, you need to get stuff. You need ablation to get stuff to go down. So the point is that you often have to consider a combination of things when you're using IVL. And so this is in the last second, the sort of a brief algorithm that we used. You have a calcified lesion. At the end of the day, you want to put in a good stent, and Shockwave falls into the algorithm down here. But what you basically do is you assess, is it crossable with the balloon? If it is crossable, then you pre-dilate, image, and if you have some of these adverse features like thick calcium, lot of arcs, large lumen. If you don't have them, then you can kind of go with a regular balloon, cutting balloon, and use Shockwave as an adjunct. But if you do have these, and especially if the calcium is deep, then IVL is your only option. But if nonetheless, you need to consider IVL, or you need to consider ablation as an option, especially when you have that much calcium, or IVL, or both. On the other hand, if you can't cross it with the balloon, then you're kind of stuck because you have to use some sort of ablation, most likely rotablation, and you can combine it with Shockwave as an adjunct. And of course, if you can't cross even with a microcatheter, then laser is sort of your only option, and that's something that most labs, unfortunately, don't have access to. So ladies and gentlemen, at this point, I will stop. Thank you very much for your attention, and be happy to answer any questions.
So that's a great talk. You went through so much of content in a very short time. Let me just ask you this. You have a very bad lesion. It's a heavily calcified at that point. I mean, what's your strategy? Do you actually center this balloon to the lesion like we normally do with all balloons? Do you put it eccentrically? Why would you put it eccentrically? And why not center the lesion on the balloon itself?
So the emitters are placed eccentrically in the balloon. So you actually have to place your balloon a bit eccentrically to the lesion to make sure that your lesion is centered on the emitter. So what I basically do is I will move it back and forth a bit, and you don't pulse everything in one spot, but a little bit distal and a little bit proximal to make sure that the lesion gets the maximal effect of the Shockwave.
So I saw you had a great picture of the emitters and the pulses.
Correct.
Pulse waveform being delivered, and it seems that it's maximum at the emitters.
Yes.
And therefore, I think the corollary of that is that if you've got a heavily calcified lesion, a non-yielding lesion, the first emitter is just 2 millimeters beyond the proximal marker. You put that first emitter, which is right on the lesion itself, so that you get the maximum pulse delivered to the lesion at that particular point. Saritha, when we do IVL, we see regularly shock topics, as they call it. We see these ectopics coming, which are sometimes of a concern. Should we be concerned about those ectopics? Can they be harmful? Can they create an arrhythmia? Patient may have a pacemaker. What's your normal practice around that? Not worry about it, forget it?
So that's a very interesting point. And yes, we do routinely see these shock topics, and they're usually a ventricular capture. But most of these shock topics are considered to be benign, and they're usually seen in patients who have an upfront bradycardia with a rate of less than 65. These are the patients who are most likely to present with shock topics during the procedure. It's not been reported that they have been malignant. There's only been one case in which there was an R-on-T phenomena in which the patient went on to have a VT event. And in that case also, they said that it could have been the ischemia because of the balloon inflation, or it could have been the underlying ischemic myocardium, which precipitated the VT event, rather than the shock topic itself. So it was not confirmed. But most of the time, these shock topics are very benign. Now, as concerns your point, Dr. Seth, about, in pacemaker patients, should we be worried? Or if this patient has an AICD, should we be worried? So most of the time, if you're going to do this procedure and if you're worried about this aspect, we normally program the pacemaker to a VVI or to a VOO mode. And if this patient has an AICD, we would think about switching off the tachycardia detection algorithm for the duration of the procedure and then switch it back on again.
That's been very, very reassuring. Yes, we do see those occasionally in patients with bradycardia. As you have a capture, you will see a transient drop of pressures as well. But we certainly have a strategy around. I mean, after all, that case report, and you're right, it's a single case report, and after all the thousands and thousands of IVL reviews, we've never seen a ventricular arrhythmia. But never to disregard the fact that we should be looking at the monitor, clearly. We shouldn't be having a discussion while we're firing it. Our sisters are always alert, and we make sure that we have a functioning defibrillator just in case that's not a situation that has ever arisen with us. But it just warns us that we should always be more, always be alert around these issues.
Absolutely.
So what about, Virat, I was going to ask you that. What's the learning curve like? When you started using IVL, your own experiences around IVL, is there a huge learning curve? Is it a safe device? Have you had dissections? Have you had perforations? That's always the question which is asked. Can it cause slow-flow phenomenon? Do you see CPK rises? After all, we're putting a device which is giving pulses at to the tune of the 50 atmospheres of a pressure on the vessel.
So I think for operators who are well-versed in treating calcified lesions and know how to use atherectomy devices, whether it is, laser atherectomy, orbital atherectomy, or rotablation, IVL most certainly is not any more complex. If anything, it's perhaps more user-friendly, and none of these anticipated potential complications of no reflow, dissections, etc., are difficult to handle with IVL than they are with atherectomy and so on. I think the learning curve is not huge at all. You just need to learn sizing. And I think that is the limiting factor in terms of dissections. When you learn how to size appropriately, how to deliver the balloon itself, some of the questions that are coming up in the chat include, if you do a small pre-dilatation initially to deliver your shockwave, does that preclude subsequently using atherectomy devices or not? In my experience, it does not, and the small ballooning that you used does not preclude anything. It does not change your algorithm if you're going to choose an additional device, atherectomy device, on top of IVL.
Great.
But it's a small learning curve. It's not huge.
It's a user-friendly device. There's no question in my mind about that. Any other questions have come up from the chat, Dr. Mirat?
Yes, so one of the questions that came up is there a contraindication when you use, when there's dilatation, after dilatation, if you have a dissection?
Absolutely none. We must remember that every balloon dilatation that we do does have dissections. That's the mechanism of action. And even after IVL, you see cracks and fissures. So in a sense, that's not a contraindication to using the balloon. In fact, I would also urge you to the fact that it's not a great idea to shove IVL through a highly stenosed lesion in an attempt to say that if I used a balloon for pre-dilatation, I'm doing a bad job. In fact, you're actually doing a good job. And every IVL that I use, I actually make a space for the IVL to the tune of 2 to 2.5 millimeters, because usually using it in large vessels, for the fact that you want the balloon to expand slightly. You want that saline. You don't want the emitters to fire on the balloon material. You want to fire them at the saline contrast mixture, and that's when you get the acoustic waves. And therefore, it's a good idea to dilate the lesion partially so that you actually have a slightly expanded balloon at 4 atmospheres and don't fire emitters. In fact, if any of you have experienced perforations of IVL, and all of us have that experience of IVL perforations, it was happening with the previous generation of IVL, which was the thin-walled IVL balloon. Since we've got the thick wall, which is the double-walled IVL balloons, we rarely see perforations. And the reason for pre-dilatation is also the fact that if there is PICUL or anything else, you would be over that. You would already know that, and your IVL balloon will not perforate. So we rarely see perforations now of an IVL balloon.
So two quick questions that came up and I think are quite important. One is, how do you protect a side branch at the site of shockwave lithotripsy? And then the next one is about sizing. So if you have a long calcified lesion, how do you determine the size of the balloon that you're going to use? Do you undersize, oversize, use two balloons, etc.?
Fine, over to you.
So two great questions. So as far as protecting a side branch, it's just like any other balloon dilatation. You put a wire in the side branch if you're worried about it and just shock across it. As far as sizing is concerned, as I mentioned in my talk, I err towards sizing it generously. So if let's say the distal vessel is 3 and the proximal is 3.5, I would take a 3.5 because you're only going up to 4 atmospheres, and I would shock it distally with the 3.5 and then shock it proximally with the 3.5. In the case that I presented, there was a big difference between the proximal and distal, so we took a 3.0 distally and a 4.0 proximally. But you err more towards having a bigger balloon rather than a smaller one because you want to maintain contact between the balloon and the vessel wall to deliver the shocks.
I think I should invite Sydney for his talk and then carry on the discussion. But while he's getting onto the stage, you want to be optimally sized, but don't feel guilty if you're slightly undersized. As long as you're hitting the vessel wall, your pulses will transmit through that wall into the calcium. The important point is not to be so undersized that you don't even touch the vessel wall or touch the lesion itself, which is highly unlikely. So, Sydney, over to you.
Thank you.
Deeper dive into performance across calcium morphologies and complex lesions, real-world algorithm from your...
So that was a great talk and a great segue to this part of the talk. We'll go through some of the data, and there's my disclosures. And we know that calcium is bad and it hinders, is the enemy of the interventional cardiologist for tracking, for complications and unexpanded stents, which lead to worsened outcomes. For severe calcification, can lead to bad events such as mortality, myocardial infarction, repeat revascularization. This is the totality of the trials, and notice that these are not randomized trials. These are large single-arm IDE studies, and you can see that the largest of the 3 is Disrupt. This is a very, very disruptive technology, and aptly named trials of Disrupt, CAD, 1, 2, 3, and 4. And notice that the 3 is the largest, 384 patients done in the US and Europe. And all of them have mandated, FDA mandated an OCT substudy, which leads to our increased understanding of the mode of action of lithotripsy. Notice that published articles are many. Interestingly, across the board, there's a consistency of procedural success and stent delivery, so it works. There are also a paucity of problems, such as severe dissections, perforations, abrupt closure rates, and even no reflow, next to 0. Residual stenosis, well, that's just related to that procedure and before stenting. In-hospital MACE events are very acceptable, consistently in the acceptable range, around 5 to 6%. Target vessel revascularization, you can see here, are very low rates, and MACE events at in-hospital and 30 days have remained very low. Let's look a little bit at the biggest trial, which is Disrupt CAD3, US pivotal. And this is done, as you can see, intention to treat population. And of course, going to be 2 years follow-up. The OCT substudy is about 100 patients, and the enrollment around 400 patients. But you can see there's 384. Procedural success, high. It works, and it allows you to have acute lumen gain and deliver your stents. Complication rates, very low. In fact, adjudicated core lab analysis shows that severe dissections are minimal, and perforation risk is extremely low, as is no reflow. In-hospital MACE events are low, as well as consistently across 1 month, 30 days. Compared to other atherectomy trials, which is usually the only other option in terms of rotational atherectomy, Rotaxis trial, the Prepare Calc, and Orbital 2 with orbital atherectomy, notice that these numbers are much higher in terms of complication rates compared to lithotripsy balloon. And obviously, we've discussed this, is that translating a usual balloon procedure is quite easy to do and intuitive for most PCI doctors. Pool the analysis, let's look at the pool OCT analysis. Notice the MSA achieved here is 6.0 post-stent, and the mean stent area is 7.9 millimeters squared. Stent expansion, maximally at the maximum calcified site, is over 100%. Notice that there is an extremely good effect in improving your stent expansion at the site of maximum calcium. And malapose structs are very minimal, less than 3.9%. Now, in terms of visible calcium fractures, as you saw from the picture from Fahim's talk, in fact, on OCT, 68% had actual visible fractures and 32, 1/3, didn't have visible fractures. On average, 3.2 fractures were seen per lesion on OCT. Full thickness cracks were about 2/3, and also one crack at least in 66% of the cases. And this is measured in terms of fracture length, width, and fracture depth. This is work from Renu Vermani looking at micro-CT versus OCT. Now, what's OCT invisible in terms of cracks may be visible on micro-CT. So this leads to an understanding, actually, we may not be able to see some modification of plaque that escapes the OCT detection. This is a quintessential case looking at calcification 360. Notice the cracks you can see and the wire artifact here, and you can expand those things, and lumen area gain is very large. Consistently in eccentric and concentric calcium, it works. Notice the MSAs are 6 millimeters or more, and it doesn't matter how much arc you have. And visible fractures here, OCT may not detect it, but your stent expansion is extremely high. And that can only happen if you've modified the calcium really well. Consistently, in nodules, calcified nodules and non-calcified nodules, it's very similar events, a similar procedure, MSA and stent expansion, suggesting that it works in calcified nodules. And the quintessential demonstration case here you can see is that a calcified nodule is modified and stent result is excellent on the OCT. So this is also in women. The women subgroup analysis here was consistent with men having a good, low, comparable 30-day MACE rates and procedural success. Let's look at the algorithm. We saw Fahim's algorithm. This algorithm is from Margaret McIntaggart and James Spratt, and it looks like a metro map. Unfortunately, metro maps are very hard to read. I don't know which station I want to get off. And I'll show you it's very similar to Fahim's. So coronary calcified lesion, is it wireable? If it's wireable, try the imaging catheter or predilation. If it's crossable to imaging catheter, image it. The yellow bars you can see are imaging runs, either OCT or IVUS. If you cannot pass the imaging catheter, it's over here on the top. The rotational atherectomy may need to be done front crossing. If you can't wire across the original lesion, maybe some sort of CTO approach, ADR, antegrade dissection reentry, bypass the calcium, may get you there. If this scoring system on OCT or IVUS is satisfied, modify the plaque, and you can choose what you think is the optimum, and then, or NC balloon if you don't really need to do atherectomy or challenging lithotripsy, then you optimize this preparation with an optimized balloon dilatation, usually NC balloon, and then you check this on the imaging run, and if you're satisfied, stent goes. If you're not satisfied, modify some more, come back, loop in the middle, and then DS implantation. You may need to do one more imaging run, which is like more dilatation if it's suboptimal. This is my own registry here, but this is curtailed from September 2019 to August 2021, 50 men out of 67 patients. So we've done more than 100 patients now. Mean age is 71, transradial about 60%, mostly LADs, and 9 CTO cases, 12 bifurcations. Imaging here was done in 88% of the cases, 2/3 were IVUS, and 1/3 OCT. Notice that we had 70% of patients having post IVL, and post PCI, and a lot of the patients had 360-degree calcium. 13% needed rotational atherectomy, median size about 3, stent length about 40 millimeters, tight stenoses, 10 only had balloon angioplasty. The stent expansion achieved was 83%. So we will wait to hear Illumin 4, where one of the subgroup sub-endpoints, secondary endpoints, was 90% stent expansion. Maybe you try too hard, you get complications. There's a talk of some issue if you get too crazy with the dilatation. But median screen time is 35 minutes. Mean contrast is 200 mils. They're complicated lesions. One patient had a problem with significant oversizing of balloon and needed surgery due to a rupture. Show you very quickly 3 cases. I didn't do this case. A colleague did this case, 60-year-old man, LAD, just stented this angiographically speaking, dilated the diagonal branch, a stent went in. On a clear stent, He could not post-dilate with a 3.0 NC balloon at 28 atmospheres on a number of occasions. He didn't rupture the balloon, but he could not dilate it. That's the clear stent with a waist. That's the OCT, showing that the MSA here is 2.9 millimeters square. The stent expansion is only 63%, a little bit of calcium around maybe 180 degrees. So lithotripsy was done. This is an ability to see the actual site of the stent residual with the electrodes and shocked about 40 pulses. And notice that balloon expansion here now is not at the site, but it's extremely well expanded and optimized result. This is the optimized angiographic result. Now, we've done some studies about, this is if you get stuck doing normal angioplasty, no imaging, no shockwave, but it's after the stent goes in, there's talk of some attenuation of the effect. We did something about, does it remove the polymer? We did a little study, this was abstracted 2 years ago at PCR, where we actually did EM studies of a various number of stents, polymer ones, Xience, Resolute, Synergy, and non-polymer create dwells, and shocked them at 0, 20, 50, and 80 pulses and look at EM study. And really, unless you get very large number of pulses, you don't do very much to the polymer, which has been experienced. We came up with a little score called delamination score, but it really, you can look at it any way you like. Generally speaking, you don't destroy the polymer unless you're really expending a lot of pulses. This is a pre-TAVI patient, case 2. Calcium is notable in the LAD, but also at the aortic valve, which is open and closing. Here, very tortuous looking, and actually quite hard to wire. And in the end, we really only wired a diagonal branch, and no balloons would cross this angulated calcified lesion, and hence rotational atherectomy was done. And after this, we were able to do intravascular ultrasound and check this, which is extremely calcified lesion. I'll just go a bit quicker with this. You can see a little signature on the lower right, left-hand corner. It allows passage. This is a lithotripsy balloon, and the waist is just a little bit better on the right-hand side, so it's modified. And we checked it again using this, and we'll see some cracks occurring in a minute here. The rotor signature, reverberation, and cracks over all the lesion. We thought this is well modified. We actually NC balloon. This is the clear stent pre and post lithotripsy, noticing the disruption of calcified shelves. Stenting procedure was optimized. We're very happy. I won't show you the last one. Case 3, very much at the end here, 74-year-old lady, previous bypass surgery, has a defibrillator actually, and you can see here some left main disease, calcified circumflex vessel. It was very difficult to pass anything, including a wire. This is a microcatheter. It didn't go. We wanted to rotablate this because it's uncrossable. However, removing the wire and trying a regular rotor floppy, we were unable to get much purchase. You can see that the rotor wire did not go very far down to allow us to do rotational atherectomy. Maybe better now with the rotor wire drive. So this is an XTR wire, and we anchor balloon into a branch, Ramus branch, and we got 1.0 balloons, 1.5 balloons, 2.0 balloons. This is a 2.0 NC dilatation, and notice there's a waist. But notice one point, this is a 2.5 NC balloon, and notice the waist is more visible. Because sometimes if you're not one-to-one sizing, you can't see the waist very well because we were able to track some equipment, but this is now clearly obvious, that's a clear stent, and this is where the lithotripsy balloon got into, as far as it would go, and we're able to shock this. We didn't change the settings of the ICD actually in this case, but we didn't have much trouble, and visibly we have modified the plaque on IVUS for allow us to see that it was very modified, and now we're able to stent it, and this is the stent result. So, thank you very much for your attention.
Thank you very much, Sydney. 2 brief questions. Firstly, you have those lesions which are fibrotic occasionally, they just don't dilate. Can Shockwave dilate those fibrotic lesions?
For fibrotic lesions, we tend to use cutting balloons and things, but I think that's why I do a lot of clear stenting to see if there's any calcium there. So obviously, if you're going to expend a very expensive device, it's not calcium. I don't believe that it would work with non-calcified lesions, so I might use cutting balloons.
And that's what you need to understand, that the pulses would just dissipate. It needs calcium to fracture. Otherwise, pulses dissipate, and that's why it's not a great tool if there's only a 90-degree arc of calcium or 180 degrees, because the dissipation of pulses would be on the other side and not towards the calcium. Mirwat, I think there are questions from the audience, and we need to address those, so please go ahead.
Yes, and for the audience in the room, I'm getting your messages. Please just identify yourself to the staff and they'll get you a microphone. So Sarita, I'll ask you the next question that did come up, and it was about how do you pace the 80 pulses? So do you have to use all 80 pulses when you're treating a lesion? And B, do you do them all after each other? Do you pause and so on?
So that's a very interesting question. Now, it would totally depend on the lesion characteristic as to how many pulses that lesion requires. Now, frequently, we are able to do a procedure with maybe just 40 pulses. It's not a compulsion to use all the pulses at one site. Second, frequently, it's an expensive balloon. So when we are using this IVL therapy, we normally like to use it maybe for 2 vessels or for at least 2 sites in the same vessel. So we space our pulses out according to what is the characteristic of the lesion. And we're always checking. So sometimes even 40 pulses does the job, so you don't have to use all the pulses at one site absolutely. You can use the pulses at different sites also. And regarding spacing, after every 10 pulses, you have to deflate it anyways. At this point, I'd also like to, just mention one of the cases that Dr. Sidney was showing, very interesting, when it was the calcification was just at the end of the left main. And the other advantage of this in left main lesions is that as compared to rotablation, you can always have 2 wires in the LAD and the circumflex when you're using a lithotripsy. And there's less amount of slow flow, there's less amount of abrupt vessel closure. And at the same time, the very interesting thing is that you can deflate the balloon at any time. You can even deflate it after 5 pulses if you feel that this patient is having ischemia at that time and the pressures are dropping.
So we have a question on the floor, I believe.
Yeah, thank you. My question to Dr. Jaffrey. First of all, fabulous talk, and you have a fabulous vocabulary. I really enjoyed your talk. One question is, when your 7 French didn't sit, why didn't you think of an upfront guideliner? Second question is, did you complete the procedure on the wiggle wire, or did you change to a normal wire before completing the procedure? Third is always a doubt that has been in my
Mahesh,
mind.
let's finish the first 2, otherwise we'll forget the...
Sorry. So the first question, you're asking about why didn't we use a guideliner up front? It's a good question. I mean, if you look at that right coronary artery in the RO projection, it literally curves like this. So it would not have been easy to get a guide catheter extension down. You'd have to anchor a balloon and all that. And of course, there's a lot of vessel injury involved. So that would have been the next step if nothing went. The second question was wiggle. So we completed the whole procedure on the wiggle. The wiggle wire kind of tends to stay very stable. It is just very difficult to manipulate without having a microcatheter on it, at least in our experience, in these kind of vessels. So once we put the wiggle, we try to put it as distal as possible and then get on with it.
So we often, in calcified tortuous anatomy, use a support wire anyway. And a wiggle wire is a good type of a support wire because it also provides you the advantages of the corrugations and therefore moving it away from some of the calcified segments where your balloon or other devices stop. My question to you, again, Sidney, was this very issue around, in the CAD studies, obviously, under-expanded stents are still, by the way, though our real-world experience has grown tremendous, it still is off-label. What's your experience with under-expanded stents? It happens to all of us. Despite whatever we say, despite whatever, once in every 3-4 months, we ourselves end up with a situation of under-expanded stents. And anyway, we get a lot of referrals with under-expanded stents. That's the other aspect. So what's your experience around these under-expanded stents?
So under-expanded stents, I guess the literature says this is a common cause of the problem. That's why they're coming back to the lab. They have a clinical problem because the stents are not good. TLR rates are high, stent thrombosis, restenosis. So I think number 1 is imaging. So you have to understand the mechanism of this. Is it just undersizing of the stent? And it'd be nice to know what stents they were. Obviously, the simplest thing is try to be luminal and then try to NC balloon dilated to a reasonable size, see if you can achieve it. Is the restriction related to the outside calcified plaque was non-modified before you stent it? And various imaging techniques, even during the case I've shown you, may help. Clear stent, stent boost, and maybe the imaging will also tell you. OCT particularly would be good to see that, but you have to interpret it. And if that's calcium, as I showed you in that case that was done, would have come back if you left that lesion, exactly what you say, and maybe you have to shock it out again. And we've seen many cases like that. If they don't have a big problem, but still come back, then yes, it still works. You may need more pulses, but it works.
That's right. So I think this is perhaps the only tool we have in our hands which is safer than ultra-high pressure balloons if there's a calcium restraining the expansion of a stent. Obviously, we should never get into that situation, and that's why we
So the other method in the literature is a laser with contrast injection,
contrast
which is
injection,
very
which is-
aggressive heating of the artery. I don't have that, but it's a very aggressive procedure.
So many people don't have the laser, and of course, we used it prior to having ultra-high pressure balloons and IVLs, but clearly IVLs become the treatment of choice for such situations.
So can I just...
Of underexpanded
one-
stents with heavy calcification around it. Please.
So one comment. So the problem with the IVL balloon, as I can see it, is that we have to get the balloon into the lesion before we can actually deliver. So if we have a smaller balloon with a single cathode or whatever that is, which is facing forwards, and we can just deliver a shock which will go forwards and crack open the lesion instead of actually having to get into it, probably we'll be able to do what the rotational atherectomy does for this thing.
Yeah, that
That's for the
question
IVL
comes up
people.
quite often, actually. But the idea is to remember you're not dilating, you're delivering shocks. So ultimately, you need to deliver that segment of the IVL balloon that will deliver the shocks to the lesion. Otherwise, what you're doing is just creating a track in order to deliver your equipment. So either use a very low profile balloon or laser to create the track and then deliver the equipment. The question that comes up very quickly is the role of intracoronary imaging when using IVL. So very quickly, does anyone from the panel want to handle that? What do you do?
Very briefly, because we run over time.
Highly recommend it. Thickness can be measured in OCT, but IVUS is also very good. So if you can do it, please do.
Thank you very much. I truly appreciate your interest. We've run over time, but this has been a great session, and I hope you benefited from the pearls of experience of our speakers as well as the panelists. Great tool, great device, low learning curve, safe enough. The only thing is it's expensive. And you got to ration your pulses, just like your bank account, your money in the bank. That's the only other thing. Thank you very much for your attention.